Hello, everybody. This third already city dialogue of the Global Parliament of Mayors. We are organizing this series of webinars every last Monday of the month on different topics of urban governance and urban analysis. As everybody probably knows, the Global Parliament of Mayors has the mission dedicated to itself. Of course, it took the mission of empowering cities. Our overall analysis is that the world has changed a lot. The majority of world population is living in cities, and at the same time, we see that global governance is still in the hands of international institutions on the one hand, and national governments in the other hands, and cities only are observers in UN Habitat or COP meetings or other types of global governance. So the Global Parliament of Mayors, who exists more than 10 years now, is a platform, in fact, for empowering cities. And what we want to do every month is to discuss with an expert a specific topic, an important theme in urban governance and in urban challenges. And today we chose as a title compassionate cities. Within GPM, we have one of the main pillars of our activities is caring cities, as we think that at a national level welfare states are declining, and that cities have to take over a lot of the problems that arrive in the concentrated society that is a city. And that's what we want to discuss with you. My name is Eric Corain. I am a professor in urban studies at Brussels University, and for GPM, I'm the director of policy and research. And our guest of today is Professor Luc Deliens, who is a professor at Ghent University and also Brussels University. And he is a sociologist and specialized in the end of life. And it's a very specific, let's say, maybe you could say a narrow thorough, but as we will see in our conversation, it really touches to all the aspects of public health and health policy. So welcome to our webinar, Luc Deliens. Maybe to start off the conversation, I would like you to tell us a bit about your activity, how a sociologist is really focused on the problem of graying, the end of life, and how did that develop in your long and international career on that topic?
Yeah. Thank you, Eric. So my name is Luc Deliens. I'm a professor of palliative care research at the VUB, Free University of Brussels, and Ghent University. I'm also the president of Public Health Palliative Care International, which is, of course, today the topic of this discussion or interview. So I started because I was educated as a sociologist, and I moved in the mid-80s. I moved with the first professor on medical sociology. I moved from the sociology faculty to the medical faculty. So I developed my whole career within the medical faculty, and I stayed all my career in the medical faculty, which was, of course, in those days not obvious for a sociologist to be in a medical faculty. I have lots of nice anecdotes, but I'm not going to bore you with these anecdotes. But I think in the 90s, I did my PhD on cancer prevention. And so I digged already at that time for my PhD quite a lot into the literature on health promotion and on prevention. And so I was quite familiar with that literature, which I found quite fascinating, but I was at the end of my PhD quite bored with the subject of cancer prevention, with the topic of cancer. And so there was a number of doctors from the University Hospital of Ghent University who invited me to join them in a first research project on end-of-life decision-making in their hospital, because they failed to do a survey without having a sociologist on board. They had a response rate of 3% in their own hospital among their colleagues of doctors. So it happened that at those days, I had just published a paper on how to increase response rates for surveys among doctors. And one clever doctor had been reading my paper, and he said, maybe we should invite a sociologist to do a survey. And that's how I got involved actually in end-of-life research for the beginning. And our first big study was a nationwide study on end-of-life decisions by doctors. And that was quite significant because it got published in Lancet, which is the main medical journal. And it was in the 90s before we had a law on euthanasia in Belgium, because in 2002, Belgium legalized assisted dying in the form of euthanasia and assisted suicide. And we discovered with our first big nationwide research that we had already more than 1,000 cases of euthanasia in healthcare in Belgium. And that was, of course, a shock for the whole society, but also a shock for Parliament. And that's how also partly the law came about on euthanasia. So from that success story, I think I was launched into the medical faculty, and I got more and more resources for doing research in my faculty. And of course, could apply for more money at the Science Foundation at European level, etc., etc. And I started doing research in the broad domain of end of life. So the whole spectrum of palliative care, which was established at that time, was really at the beginning, was being developed in our country. By the end of the 90s, the first initiatives on palliative care services developing started, and I started doing also research. And most of my first, let's say, 10 years, 15 years, maybe longer even, of my career in end of life was actually very clinical and health services related research. And it was not until like 10, 15 years ago that I immediately got the interest back again into public health approaches in palliative care, because, well, everyone knows palliative care, and that's associated with doctors and nurses who are taking care for the dying people in our society. In practice, is very often terminal care. So there's two main issues which actually was brought to my attention. First issue is that there was a lot of research about active aging. And so the active aging spectrum of research was doing all kinds of health promotion towards an graying society. But those graying society people never died in the active aging. They never died in the active. So the active aging movement and also research was all like of a continuity of youth people through their life, and without talking about that and dying. So that was my first observation. That's weird that there's a full domain of aging, of active aging, without taking into account reality that so many people, and you probably, some of you have their personal experience, are confronted with death and dying in their, especially when they have an advanced age. You are confronted almost monthly with some family member or with some friends. So that was my first. And my second acknowledgement is also that health promotion didn't really focus on palliative care. Mm-hmm. Although I knew from my previous research that there's so many interesting stuff that could be applied to palliative care, but has never been established. So another development was within palliative care, which was actually very complementary to my first insight. So the second insight was, in palliative care, society was completely absent.
Yeah.
So everything was medicalized, So all models of palliative care that were developed, including by my research team, were medicalized models about integration of palliative care in cancer care or in pneumology care or in neurology care or whatsoever. But it was always professionals coming together, ideally integrating together into a new model of care. But society was completely absent, although more and more evidence in palliative care was showing that a lot of problems in palliative care are social problems. And a lot of problems in palliative care are mental problems. So the absence of society was a bit weird in palliative care, because many of those problems can be coped with within the societies, within communities, within compassionate communities. So that were the two major insights that pushed me towards more sociology again into my career, towards more public health approaches of palliative care.
I think it's fascinating, of course, because yes, if we think about dying, we think of sick people, people that are already related in one way or the other with doctors in a certain way, and it's becoming a medical problem. But I really think in a graying society where a growing fraction of the population is old, where our life expectancy is becoming longer. We have, of course, a lot of old people in good health, but they are also going to die. And that's a very interesting insight to tell us. Could you give us some data about what is the fraction of those people who remain in health, you could say, who remain at home, who remain embedded in their social structures, more than being in hospital already when the end of life is approaching?
Well, in a country like Belgium, where we have 11.8 million inhabitants, there's roughly 100,000 people die every year. But that's only the people who die. 2/3 of those people, which is 66,000, 2/3 are going through a disease trajectory. So with lots of burdensome treatments, with lots of suffering, etc. So that is the majority of the deaths are non-sudden deaths, as we say. So deaths that can be predicted by the doctors, that it will happen. For example, if you have a diagnosis of stage 4 lung cancer, you know that you're going to die from your disease. But it might take, I mean, even with the best medical care, medical treatment options, you might still live like 1 year or 2 years. But you know that it's going to be a period of a lot of caregiving. And so the question, of course, who is going, I always ask my friends and my families, if there's an opportunity to ask them, who is your most important caregiver? If you're going to die, who will that be? Your most important caregiver. And then they start reflecting, because most of them haven't reflected yet about these issues. And then they may say me, my GP will do that. My general practitioner, family doctor will do that. And I say, I don't think so. Will your GP cook your meal in the evening for you? Will that doctor go to buy your groceries, to cook your meal for? If you have a dog and if you can't take your dog out anymore, is that GP going to take your dog out every day, twice a day, or 3 times a day? No. So these are all social activities that's going to be done by your loved ones, by your direct family, by your neighbors eventually. And as you know, well, in Brussels, you know it very well, Erik, 1 out of 3 households are single households. Yeah. So cities have to ask themselves the question, who's going to take care for these people? That's the big question. That's, for me, the biggest question for the graying of our societies. Who is going to take care? And I'm not speaking about doctors in my approach. I'm speaking about the daily care. And we know from research, for example, also, even in a hospital, Erik, only 5% of the time you have next to your bed a professional carer, a doctor or a nurse or physiotherapist. The 95% of the rest of the time is filled in by your loved ones, by your children, by your spouse, by your family, by friends, etc. So we need to ask ourselves in our society and in cities, especially in city centers, how are we going to fill in this 95% of the time?
Yes.
And so we have to reinvent the city centers to make sure that there are spaces where people can connect to each other and create also spaces for people up to the end of life.
Yeah.
Because people will not be dying in hospitals in future. I mean, most of the people will be dying in the communities. And so the communities are not ready right now.
Is that perspective that you tell us not, let's say, especially related to, how would I say, Western modernized cities where older people are separated from active people and where medicalization is very in most parts of the world, you still have this connection with society, or is that not true?
That is true. I'm just coming back from, I was in September at the African Conference of Palliative Care, also giving a keynote on public health palliative care. And it struck me really that some of the reactions there is that exactly that the same problem occur in their city centers. So not in outside the city center. There you still have this community, and that's why I think compassionate communities is much more easier to implement in Africa than it is in Europe, definitely, because they still have this connection to the community. You know, the Ubuntu philosophy of Africa, that means that I am because we are. So the identity is the group identity, while in the Western world, it's the individual identity. So that is a huge difference. But what I was hearing at that African conference in Botswana is that actually the same process is taking place in Africa, especially in the big cities, in the city centers, where people are really pulled away from their extended families. So it will be becoming also a problem in these continents. But of course, the most, I mean, we know that from European value studies. I mean, all those societies where person's values are prioritized for personal decision making, independent from family and extended neighborhoods, etc. It's a bigger problem.
Yes. So it has to do, of course, with urbanization also. Urbanity in all parts of the world develop forms of atomization, of individualization, of division of labor very much. And so an urban community is never like a village. We cannot compare neighborhoods with villages. That's not a good way of doing. I agree. I agree with that. But then, of course, what should be our attitude then? How can we, within this urbanized world, improve healthcare or public policies or change our mindset? Because what you say is clearly it is not hospitals alone that are going to deal with that problem.
I would again refer to the African conference, well, not to the conference, but to the African saying is that it needs a village to raise a child.
Yeah.
I think we need to realize that also it needs a village to take care of death, dying, loss, and bereavement. In Belgium, to go back to the figures, next to this 100,000 deaths every year, out of the 11.8 million inhabitants of Belgium, 1 million inhabitants every year are confronted with the death in their closed family circles. That's a huge amount of people. That's a huge amount of people. So I think if society doesn't realize that we have to take care for these people, I mean, we're gonna only increase the loneliness in our city centers. We're gonna increase problems of mental health, suicide issues, etc., that are gonna raise. So the only answer to those questions, to those really, really challenging issues, is social connection. That's the only answer. And every kind of way we can create social connection in a city is a good way. So there's not a bad outcome for social connection. You know, health already is determined by social determinants more than it is by how to say, yeah, by your inherited health, or by all. So social connection is more predictive. So the number of social networks that you have is more predictive for your health than the number of health services we have in a city or in a country. So we have to start realizing that social connection is key to a healthy lifetime for as long as possible during your lifetime. And that's the same for death and dying. So death, dying, and loss is part of our society, and we should acknowledge that.
Yeah.
We should acknowledge that. And recently, well, a few years ago, Lancet published a commission on the value of death, which was revolutionary for medicine. So it was a commission who needed to make a position paper for Lancet on the value of death. And they actually came out with a very, very clear statement about not only we have to normalize death, dying, loss, and bereavement in our societies, which was the case 50 years ago. When my grandparents died, they died just in the community. And they were taken care by the neighbors in their last weeks or months of life. And even during the funeral, they even closed down the motorway between Brussels and Leuven to bring my grandfather to the church for the funeral ceremony. So that was really, it was still part of the community. So I think the first thing is we need to normalize it again. And there's lots of techniques and policies within health promotion how to normalize that. So that's not a problem. We have done that for health. Everyone knows what healthy food is. Everyone knows what healthy lifestyle is. A lot of people are empowered to do so. If you see the number of sports club, etc., even schools, children at the age of kindergarten, they learn what a healthy breakfast is. So we know that how to empower, how to inform, how to increase awareness among the populations. We just have to apply that also for death, dying, loss, and bereavement. So that is very, very important that we create that and that change that kind of attitude. So normalization, I think it's the first thing that we can do. And now Lancet is I think they are preparing a second phase in that development on the value of death, which they published a couple of years ago. So we need also to realize that prevention. I mean, if we talk about death and dying, it's also about prevention of suffering, and prevention is not being applied very often. I give you one example, which the oncologists are not very happy when I raise that issue. I proposed, for example, in a conference of oncology, that Parliament should vote a law to forbid an oncologist of starting off an experimental chemotherapy with their patients, not until that patient has seen a palliative care doctor.
Yeah.
That is prevention of suffering. It just by a simple law, by Parliament, you can reduce enormous amount of suffering. We know from our research and from many other research that even in the last days of life, cancer patients receive chemotherapy or radiotherapy, etc. More than 20% of cancer patients in Belgium receive chemotherapy in the last 3 days of their lives. It's ridiculous. It's only adding suffering to the remaining days of life. It's not preventing suffering. So there's a lot of preventive initiatives that can be developed over the years to really, in a structured way, just like we do with, like, for example, mobility or car safety these days. I mean, if you look at how do we drive these days from point A to point B, and how come that we arrive safely with our car somewhere? Just imagine how many public health measures there are as soon as we start our engine or we open up the car is filled with all kind of technology which makes the car much more safe. We have seatbelt these days. The road infrastructure is so that we have lots of road bumps, so that slow downs our speed. We have speed limitations board. We have controls by the police, but also we have our own education program. We learn how to drive a car. We have to pass an exam to use a car. So there's lots of, these are all public health measures.
Yeah.
But these kind of public health measures we don't use for death, dying, loss, and bereavement. Although we, as I said, there's like 1 million people confronted with a death one in their close family members in Belgium every year.
Yes, I think, I mean, you made a very clear argument in favor of, let's say, putting health as a community question.
Yes.
And of course, it's a question of scale also, because health policies are normally, let's say, initiated at the level of the state, of the national state or regional states, if you have a federal state form. But anyway, they, of course, have a kind of administrative bureaucratic approach.
Yeah.
My question now is, I mean, a lot of these questions are, of course, felt in an urban environment. So as a mayor or as a city government, you should not copy probably the state, make it a health policy at the level of a state and then make it smaller or adapt it to your own city. It should change of nature in a certain way. Maybe you have to let's say, to argue a bit about that. What has to change if you want an urban form of caring cities or compassionate cities? What elements should be positioned in a different way than at the level of the nation state?
Well, first of all, as I said, it's all about social connection and creating potential social networks around the people in need for care, in need for support in their bereavement, etc. So this is how you can, and you can do that very small scaled. You can do that in a larger scale. It can be a street, it can be a neighborhood, it can be a village, it can be the whole city, it can be even the whole state. I know that the state of Western Australia wants to become a compassionate state now, because they have lots of compassionate communities already in that state. So that is everyone can do that. I mean, as you know, our university is a compassionate university. So a community can be defined in very different ways. So it does not need to be a geographical community. It can be also a digital community, as long as you can create social connection with your community. And as long as these people are very well aware about the needs in that community. Because it's about opening up the box of, well, some of the research have shown, for example, that in a community, there's two main problems on a communication level. People it's very difficult for people to ask for help.
Yeah.
And the second problem is connected to that. It's very difficult for people to accept help. You know it from yourself. I mean, if you're, I don't know, if there's a problem and you always refuse the help of your friends at first because you think, I'm going to manage myself and it's going to go over and I will manage. So these are the two major problems. And that's because we think we can manage in an individual way. And there's always a point in your, if you have a serious illness in your disease trajectory that doesn't work anymore. And very often it's too late then. It's too late. And that's why I say to my friends always, you have to start thinking about who is going to be your social network when you're going to be ill? Because these people are going to be the crucial friends for you to help you out for your cooking, as I said, for any kind of activities, to do your gardening, if you can't do your gardening anymore, etc., etc. So these are the most important thing, and cities can facilitate that. They can facilitate that on a city level. They can facilitate that on a local street level, on a level of a small neighborhoods, and that's why we have also these compassionate neighborhoods projects within the cities. And we have, of course, well, on the city level, we have the Compassionate City Charter, which just put forward a number of ideas that city governments can develop for their cities. But it all comes back to the idea of, well, you have to realize fully, which even there's not one level in our society, a political level, that understands that dying is a social event with a medical component. It's not a medical event with a social component. That's a very simple statement. But if you think it through, you know that your society is responsible for a good dying trajectory. It's not the doctors who are responsible. You need doctors once in a while. You need a nurse once in a while. But the quality of your trajectory, of your caring trajectory, is going to be determined by your societies, by the communities.
That's very clear. So, I mean, you're really stressing the importance of social connectivity. And so, I mean, the first, let's say, conclusion would be cities have to work to social connectivity. But my question would then be, I mean, is that then part of health policy, public health, or is that part of overall policy? Because probably it's too late when you are ill and you need to ask help. So social connectivity should be part of economic policy, of social policy, of spatial policy. And within that, health would then be a specific part. Maybe you have to make a bit more concrete what you mean with compassionate neighborhoods or compassionate cities, and what is your work meaning in that sense?
Yeah, I fully agree that it's out of the traditional box of public health. So it needs to be approached intersectorial. And so the last time when I met the previous Minister of Public Health in Flanders, I said to her, you know, I'm not coming to beg for more money for palliative care, which normally happens when people visit the minister. I said, but please do me a favor when you, and I knew that she was going to negotiate probably the next governmental agreement for the Flemish government. I said, please be aware that palliative care is everyone's business. So it's the responsibility of the Minister of Economy, because the Minister of Economy needs to develop compassionate workplaces. It's the responsibility of the Minister of Education, because the Minister of Education needs to stimulate compassionate schools, compassionate universities. They have to facilitate schools becoming compassionate schools. They have to facilitate to have more debt literacy at school for the children, so that the taboo, that's another issue. So we need to take away the taboo about talking about death and dying. So the communities, the social connection in the community will also take away the taboo. And the taboo is really preventing people from talking to their doctors timely about their preferences. So we need to open up the box and embracing that dying is part of our health. It's not part of our death. It's part of our health. And as soon as we can start talking normally, and that's why you have to do it at school. So I give the example of the Minister of Economy, the Minister of School. Any kind of minister will be responsible for more compassionate communities and compassionate cities. So I fully agree that it needs to be a responsibility of all the different ministries or most of the ministries that can have an added value in this. And actually, what we should understand is that palliative care, in my view, in my definition of palliative care, it's not a medical definition of palliative care. It's a social definition of palliative care. Palliative care is everyone's responsibility. Everyone can have an added value for their neighbors or for their family members or whatsoever in taking care for people who are even at the end of their lives. I've done that for a lot of people already, and the main problem are always social problems. Is opening up the discussion with the family members, moderating between family members. I've seen it happening in my family, how complex, as soon as people are on their dying trajectory, lots of, well, how to say, suppressed problems in the family comes up. Yeah. And you have to talk about these issues.
But in our field of let's say urban studies, what we see happening for, let's say, socializing in general is, at the one hand you have the state, I mean public authority delivering public services. At the other hand, you have the market with let's say exchange, and you pay for the services you can buy there. And what you see in cities happening today with the decline of the welfare provisions in general is what we call the commons, is a kind of reciprocity in different fields, food policy, repair cafes, and all these kind of new type of initiatives where people connect in a different way than just a service, a public service, or something that is commercial. What do you think about that field? Because I think you argue for more connectivity, more reciprocity, basically. Yeah. And how could then health or compassion, what is in what sense is compassion different than solidarity, for instance? Could you maybe elaborate a bit on that?
Well, I think solidarity is, of course, part of compassion, and I mean, what you're looking for is activated citizens who are not just having a kind of how to say passive, maybe rhetorical way of expressing their compassion, but you need an active way of compassion, and that's solidarity in active. I mean, it's just like our welfare state has been established by activated citizens. It's not been invented by government or by political parties. It's invented by activated citizens. It was invented by volunteers who were sitting in the bars, in the cafes, as we call it in Belgium, collecting money from the community and managing that money so that in case one of the members of the community got sick, you paid out of that box from the community. So that's active solidarity. That's active solidarity. That means that you know who is sick in the community and you know who is in need for money to pay the doctor. And so you use that solidarity in order to pay for that person. That's the same with compassionate communities. You need to have activated citizens who know who is the person, who are the persons in need in the community. And how can we then respond as a community to those needs? It does not need to be financial needs. Like I said, the example is, there's even people who are, who lose their spouse at an early age. So they still have small children. And then is the question, who is going to bring the children to school or pick them up at school? It's all about connection and knowing that there is a problem in that family with those kids. And so I'm just offering my car drive together with my kids to pick up the other kids. So knowing the needs and the problems in the community is key. And second is creating enough capacity. And that's why I say also the biggest capacity for palliative care is not within the professional services, it's within the community.
Yeah.
Because you just have to empower that capacity, and you have to, and that's what compassionate communities is all about. And now worldwide, we have massive numbers of compassionate communities being developed, and it can be very small scaled. I visit, for example, a very small compassionate community in Australia, which was exactly about widowed women, very young widowed women, who just found each other via the internet, and they just decided to have breakfast together on every Sunday morning. And so because they can relate to each other, because they understand the challenges of being a young mother without a partner and having to raise 2 or 3 kids, etc. So they help each other. And so you have plenty of compassionate communities across the globe with all different purposes. And actually the compassionate city is just facilitating all these compassionate communities within the city. So you can have different compassionate communities within the city. But of course, it's just like with health. We were promoting health, but as soon as Health for All by the year 2000 was established by the WHO, and then we had the Healthy City Project by the WHO, all the local cities started developing healthy policies, which was linking up all the activities for what you need to facilitate this promotion of health in the different communities. And that's what cities can do also here. And that's actually what the compassionate cities can do. They can establish a compassionate policy across the different sectors. So it's not within the healthcare sector. The healthcare sector is only a minor sector which needs to get involved. And eventually does not have to get involved. Ideally, it gets involved, but it's not necessary to get involved. And it might start, it depends where it always starts. We start always with a kind of mapping of the assets of the community, not of the services. The assets of the community. There's always, you gave a number of examples of these new social initiatives like second-hand clothes shops, etc., etc. So this is exactly a very good example where the community is taking in charge of a crucial problem. People need to have clothes and they don't have the money for that. So you organize with the society all kinds of possibilities who have to distribute cheap clothes in different communities. And those communities can also, it might be that the asset for a compassionate community is within that social connection already. Yeah. And you build upon that what exists already. So that's perfectly possible, yeah.
So I learn already if I have two elements. So good urban governance should be facilitating form of governance based on a diagnosis of the assets that are already existing in society, not just in the formal structures, but also in the interaction. But then I come to one of the crucial questions, of course, is time. Do people have enough free time to be an active citizen in a certain way? Because of course, labor for the active population is taking up a lot of people. So maybe, I mean, that's just an idea that came up in our conversation, is that especially you could orient to the elderly still in good shape to be part of such compassionate communities or activities, or unemployed people, or I mean, there's a lot of people who are not integrated in the formal labor market, and that could be activated in such a vision.
Absolutely, absolutely. And I was a couple of months ago at the first Australian Compassionate Communities Conference. And the audience was like 250 people in the audience, and most of them were elderly people in the audience. So they were the activated citizens in Australia already. And I started my presentation with saying that you are the treasurers of compassionate communities. Because they are the activated citizens are really the assets that we need in our society. And opening up the box and talking about these issues and educating each other, because that's what we do. Because they all have their rich experiences. They have their lifetime experience, but also their experiences with serious illness. Many have already been diagnosed with a serious illness. They know what you are facing in that kind of experience. And they know that these challenges are social challenges and not the medical challenges. So they can relate to that issue. So it's I think I fully agree with you that probably in that direction. But also, because I give you another example, you do not have to exclude the youngest people, because I know in a public health approach in India, where they developed the palliative care services through students of medical school. So they don't have professional palliative care services, but they have created services based on medical students. And so now they serve the whole state. One state in India is being established through these volunteer works of students. And you have every year new generations of students, and they all are integrated into the services. So I would not exclude other generations, younger generations, in these developing. But of course, the elderly, especially also in Western Europe and in Western world, there's a large potential there.
Is there any way, because I know you're chairing a global network on these matters with, amongst others, compassionate neighborhoods projects. Is there any way of getting access to the information, good practices, best practices? Is there a platform to be informed about these evolutions?
Yeah, so we have a website. So it's phpci.org. It's the website. And we are now just launched a program on endorsement of compassionate communities. So most of these endorsements or these programs will appear on the website. We have already a number of compassionate cities that are presented on our website. I've just, before the meeting, there's some information about the compassionate city of Bern in Switzerland, of Bruges in Belgium, of Taipei in Taiwan, of Vic in Spain, of Köln is a compassionate city, and they have now a big conference in beginning of November for the Germanic part of Europe. They have a caring community conference, because they call it also caring community conference in Köln. There's a city in India, in Scotland, in UK, Canada, Australia. So there's a number of examples already. For sure, we need to improve our website to make it more attractive, but that's a work for the coming months.
Well, we didn't have any questions from the audience yet, so we are going to the end of this webinar. I really was a passionate conversation. I learned a lot of things, and what is so interesting, I think, in your work and in your approach of things is that you come from a rather specific problem-solving domain, the end of life, and we end up in restructuring the whole way we look at society, we look at connectivity, we look at each one's responsibility to that. And I think for an organization like the Global Parliament of Mayors, it's very interesting to listen to such arguments and the conversation. What I learned is that if the welfare state, which is a conception that is really based on the national community, if that is declining, and it is declining in the whole world, as we know, if a lot of problems are concentrated in cities, cities have to deal with them in another way, in another approach, which means that mayors and aldermen need to develop a facilitating city to live together with their community. And it's so not only a question of delivering services, of solving the problems in the name of the community or in place of the community. We have to work together. We have to co-produce an urban life. That co-production needs, let's say, proximity in a certain way. It depends. Bigger cities have to do neighborhoods or district, let's say, policies so proximity seems a very important element in that. And then integrating, of course, caring, health in an overall policy of more connectivity and more social, let's say, social responsibility. But that's a lot of changes that we need to implement today. Do you agree with such a summary?
Well, I agree, but I think it's more than that. I think you need to create new spaces in city centers in which people can meet each other. I give you one example. Hospitals, for example, they all have a cafeteria or a restaurant. And now they're very often very closed off from the community. So new hospitals should have upfront a restaurant which is open to the community, which is living next door, and never enter the hospital until they are sick themselves. So that's a crazy idea. All that infrastructure is completely hidden, and as a consequence, we also hide away serious illness. We hide away death and dying in our societies. So it should be embraced in our societies. And more also hospital directors are thinking about how can we have a more outreach to the community. But it should be a more overall policy, is that if they build a hospital, they should start thinking about the community spaces in the hospital and not just the medicalized spaces in the hospital. Because also in hospitals, you will need more and more. I mean, as I said, 95% of the time it's filled in by family members in the even in hospital. So even in the hospital, you need more and more volunteers working. Another example, which is inspiring also, there's an experiment, I can't remember the name in Brussels, but there's an experiment of a compound, an industrialized compound of 40 apartment flats who have been refurnished in really apartment flats that went on to the private market. And there were only 39 of the 40 were sold on the private market. But every new owner has to buy in that 40th apartment flat in the city center. And that's where they're going to deliver now palliative care in that compound. It's meant to be originally, I don't know how it's worked out now, but it was for birth giving and dying. And so everyone is now owner of that 40th flat that will be the space in which that community of that compound will come together to organize the care for serious illness in that community, which is fantastic, because that's what we need. We need to really create space where people can connect for the purpose of caregiving.
Yeah, absolutely. Very, very, very insightful ideas. I really thank you very much for this insightful conversation. There were some the practical questions, so we're gonna share the website of Professor Deliens and his global association in the podcast that is following, and in the information that is following this webinar. So thank you very much for this webinar. We'll propose another webinar in 1 month time, the last Monday of November, and then we will discuss human rights in cities, how to develop them, how to monitor them, and what is at stake at that level in the urban context. So we invite everybody to join us again next month, and for the meantime, keep healthy and keep connected with other people, because everybody in the end is going to die, of course. Thank you very much, Professor Luc Deliens, for this interview.
Thank you.
Bye.